All right, good morning. So we'll pick up here. We're just finishing up here on the muscular dystrophies. One more to talk about, and then we'll get into inflammatory myopathies. And we'll do just a little bit of review of some first-year material via some questions. So here's one. If you've looked ahead in the slides, you've seen this one. So let's just make sure this works, first of all. Okay, so let's show results. Good. So you remembered? Yeah, I know. You can fix your answer if you want to. But so remember the trochlear nerve and its intorsion when the eye is laterally, that it's mainly a depressor when the eye is looking medially. And so patients that have a trochlear neuropathy complain of double vision. Okay, so optic nerve lesions, of course, that would be visual loss, right? Not double vision. So any of these other answers here could give you double vision. If you had a sixth nerve palsy, that's just going to be pure horizontal diplopia, and you would just tilt your head to one side or the other to bring the images together, but you wouldn't have to tilt your head necessarily to one shoulder. The double vision when walking downstairs, remember that's the down and in function of the trochlear nerves. So that's the right answer. You tilt your head to the opposite shoulder. Okay, so this would be a left trochlear neuropathy. Okay, we'll do some more questions here today. So our last one that you need to know about is FSH dystrophy. And it's nice when there's a name that pretty much tells you the muscles that are weak. Now there's one exception though, very important exception to this. Okay, you can see it's not real common. Okay, most individuals are symptomatic, you know, teenage years, early 20s, something like that. But this is another like myotonic dystrophy. Remember we've said some conditions in neurology are very predictable. Duchenne's tends to be very predictable for the most part. Myotonic dystrophy, and this is another example where within a family of lots of individuals who have it, some are affected early and some not until middle age. Okay, so a bit unpredictable. Okay, usually facial weakness is the first manifestation. That's usually not why patients come to see a doctor, but that's usually when you take a history, the first thing that's noticed. So family will just say there's just a lack of facial expression, appears somewhat different. Unable to smile, or the smile becomes weaker. Unable to whistle, okay, because you have to have good facial musculature to do that. Okay, using a straw is difficult because, you know, just to be able to suck on a straw can be a challenge for these patients. And eye closure, what you look for when you have someone close their eyes is can they bury their eyelashes. You should normally be able to bury your eyelashes if you've got strong musculature there. So an inability to do that, or sometimes we'll ask a patient to close their eyes and then we'll lift their eyelid up against resistance, and it's just easier to do in these patients. So I found, you know, asking patients, can you whistle, can be helpful, but you need to know, could the patient whistle before? You know, have you ever been able to? We had a famous world expert on muscular dystrophy come to Loma Linda years ago and did a grand rounds, and we brought in a patient who had FSH dystrophy, and he asked the patient if he could whistle, and the patient said no, and then he went on a long 5-minute talk about the importance of that, and then the patient humbly interjected, well, I could never whistle. So that was, you know, kind of, so you need to know, could you whistle initially? Okay, so but what really bothers patients, usually why they end up coming to see a doctor, is the scapular and the shoulder weakness is really bothersome. Okay, and so this is kind of interesting because all the scapular muscles and even down to the biceps are affected, but the deltoids is interestingly preserved, which just structurally, mechanically results in kind of an unusual thing, and that is when the patient tries to raise their arms, and I'll show you this on the video, the scapula ends up just going straight up. And so just as you're looking forward at the patient, you're seeing the scapula come up. It's kind of a strange appearance. So they have scapular winging, but then that kind of upward protrusion of the scapula when they attempt to raise their arms. So FSH doesn't quite describe everything. These patients also tend to have weakness of dorsiflexion of the feet. So another kind of exception to our rule here that myopathies, yes, it's usually proximal weakness, but here the tibialis anterior, which dorsiflexes the foot, is also affected. So these patients will frequently have a foot drop. Okay, so again, the severity varies dramatically, even within one family. Typically, these are very slowly progressive. So I've seen a lot of these patients over many years, and they don't change much from year to year. Over a long period of time, they may have some progression. So life expectancy not reduced. It's about 1 in 5 that have a more severe form, where they end up in a wheelchair. All right, so here are some patients. So you look for scapular winging. Now, you shouldn't confuse this like with the long thoracic neuropathy. So remember, you get scapular winging with that as well, but that's just going to be, you know, an isolated, focal scapular winging on whatever side is affected. FSH, you know, affects the face, affects the humeral muscles. It affects the ability to dorsiflex. So you shouldn't confuse the two. Notice when this patient tries to raise his arm, there's the scapula sticking up right there. Okay, and so here just a drawing that Eugene Kim did some years ago to show you scapular winging, and she's trying to indicate here that this patient has a foot drop, so he has to lift his leg up a little bit because the foot is flopping down. The cartoon here is to show you, oftentimes when you just get a picture of someone with facial weakness, you know, well, it's hard to interpret. What we really need is a video then here to, you know, tell Mr. Jones, can you smile? And there isn't much change. Okay, so this is to kind of show you the before and after, and in severe cases, they just really have a great inability to smile. So this is autosomal dominant on chromosome 4. There's a genetics test for this, so it's easy to diagnose. And typically, this is not a mystery because other family members have it, and so the patient will come in and say, yeah, I have a family history of FSH dystrophy. Okay, so again, we still don't have anything curative for these conditions, but remember the AFO, so for patients that have a foot drop, that this can be quite helpful. And there are, again, in a muscular dystrophy clinic, we usually have an orthopedic surgeon there for a lot of things that come up. So this is another example of it, where they can do a scapula stabilizing surgery, which for some patients can be quite helpful. All right, now, I forgot to mention this, but I wanted to just show you, and as long as we're doing it, I'll show you a video here, that if you go to the Canvas site for neuroscience, and we will be uploading more of these here, but there are videos. Okay, so you can click on this, and 2 of these are videos of patients I saw a long time ago, just to illustrate that they have pretty significant proximal weakness, but they're strong distally. Okay, and so here's a patient way back in my fellowship. I think I did the filming for this, who has FSH dystrophy.
We have an opportunity to talk with Gary Parmenter, a patient who we first saw at 15 years of age. Gary is now 21, and I would like to have him review with you some of his symptoms. By background, I should point out that Gary has had some muscle weakness since early teenage years. He has a brother and a father with a similar muscle weakness. And Gary, I wonder if you could just highlight for us what you see are the major symptoms of muscle weakness that you've had to deal with.
My face and my lower back.
What happens with a lower back weakness? What has been the biggest problem you've faced?
When I'm sitting for too long of a period, or if I'm walking for a long period of time, it swells up.
Right, and then recently you've had another problem.
Yeah, with my left knee.
What happened there?
It gets numb sometimes and
He's
swells
had some
up.
orthopedic issues, which
If I'm
I
at
don't
it
think
for a
are
long period of
directly
time.
related, but
Now,
the video of his
in
face shows up
association
better
with
on this
facial
monitor,
weakness,
so you might want to watch
uh,
this again.
What are some of the things that you've heard people say to you? Do you
Sleep with my eyes
sleep
open.
with your eyes open? How about whistling?
I can't whistle.
Give it a try. Have you ever been able to whistle?
It's a good question.
Okay. Now, you mentioned something about your arms being a little weak. What's the problem there?
I can't really lift weights or lift because of my shoulder blades. They go into my rib cage.
Thanks. Close your eyes very tightly, Gary. Open fast.
Now, if you can see there,
Close them one more time.
he can't
very
bury his
tightly.
eyelashes.
Thank you.
So there's
Wonder
some
if you could
facial
smile
weakness
for
there.
us. Okay.
Kind of a weak
Big
smile.
All right. Thanks. Now, one more time, if you could try to whistle for us, real hard.
Just can't purse the
Gary,
lips
I
together.
wonder
there.
if you could elevate your arms one more time
Can you see the
and try to get
scapula
them
rides
over
up there?
your head as best you can. Okay. Thank you very much. And now, if you could just press the palms of your hands together real powerfully, hold your arms down low.
That'll often
Hold
bring
them
out
up
some
high in the
scapular
air as
winging
best you
doing
can
that.
and push them together. Fine. Now, with your arms at your sides, bring your arms down very tightly. Ready, go. Hard. Hard, hard. Relax. Do that one more time. Really hard. Relax. You mentioned to me that you've had some discomfort in that left shoulder, and that is...
So it is often uncomfortable with your scapula moving around like that, especially, you know, you're trying to lift objects up above your head. And so this can be uncomfortable for patients. So remember that get an orthopedic surgeon involved. Sometimes that can be helpful. Okay, so let's just go through, and we haven't covered a lot of material yet in the course, so a lot of this is going to be from first year, and I think most of these are UWorld questions for neuroscience that I've a little bit not copied and pasted because I don't want to get in trouble, but reworded just a tiny bit. Okay, so let's go through a few. Okay, good. So from last year, we talked about the importance of the voltage-gated calcium channels, and that the influx of calcium is really the key event that leads to fusion and release of the neurotransmitter vesicles. And we'll talk about this tomorrow morning and just very briefly as a review about the snare proteins and how that happens. Okay, so we're going to go through, I don't know, at least 10 different seizure medications, and they all have a different mechanism of action, but this is the mechanism of one of them that we'll talk about and how that affects the release of neurotransmitters. Sorry. There we go. Okay, little deja vu. Same question, okay, just asked in a different way. All right, good. So that's the example of a kind of a neurophysiology question. Okay, here's one that'll be a little less familiar to you. All right, good. We didn't really talk about B12 deficiency in a lot of detail. We had a case study on it, so that's where you would have gotten it from the first year. Next week, we'll go over spinal cord. Yeah, I need to lock this, but anyway. We'll talk about spinal cord disorders, and I think B12 is really the best place for that. Even though patients with B12 get a peripheral neuropathy, as we'll discuss, the major manifestation is what happens in the spinal cord. So it's posterior column demyelination. That's the main thing. And so patients that have B12 deficiency come in falling. That's the usual presentation because they don't know where their legs are in space. They have a severe loss of proprioception. Okay, so we'll go over into all of these conditions. Whoops, should be multiple sclerosis there. And I think you'll be comfortable with these here at the end of next week. Okay, here was a UWorld question from yesterday's lecture. Oh, I shouldn't have narrowed the list for you there. Oh well. All right, pretty straightforward. Myotonic dystrophy question. And so the other thing that I didn't have a question here, but there was a UWorld question, and they wanted you to know the genetics of myotonic dystrophy. Again, remember it's a trinucleotide repeat. So you're going to know 4 trinucleotide repeats here by the end of this course, and those are just favorite questions. Okay, first I'll show you the scan, and then the question. Okay, now here's the question. Okay, so right answer was B. Okay, so let's just go back here. And this can sometimes be difficult. Now, first of all, if you have an elderly individual that falls, just the story would lean you a bit more towards a subdural hematoma, because that's really common from shearing of the bridging veins in the elderly. What suggests that this is a subdural hematoma is epidural hematomas tend to wedge like this into the brain. So epidural hematomas, that's the arterial blood that is from laceration of the middle meningeal artery. And all of those patients have a skull fracture as well. Subdurals tend to layer out along the entire surface of the brain. This one's maybe a bit more challenging here, but they tend to cover basically one whole hemisphere. So what's happening here is the patient is obviously lying flat for the CT scan. And so this is more of the acute blood, and dark is older blood. So this tells you this happened, well, it's fairly recent because we do have some acute blood, but it's not like within the last hour or two. So this has been there for a while. If this were all dark, then this would just be a chronic subdural hematoma. Okay. Notice also that here we have, fairly significant atrophy. The sulci are a little bigger than they should be. Just compare to this side here. Notice that we lose a lot of the sulci. This would indicate there's some pressure, some mass effect in the right hemisphere here. All right, so let me just go to the slide here. We did this very quickly, but when we talked about the cerebellum last year, I mentioned that there is this condition called paraneoplastic cerebellar degeneration, which most often is related to certain types of cancers. Remember, paraneoplastic is not the tumor is directly present causing mass effect. It's an indirect autoimmune kind of effect of the cancer. And so ovarian, breast, and small cell lung cancer. So here we have a smoker that's having kind of a progressive ataxia, and you're told in the vignette, here autopsy shows extensive cerebellar Purkinje cell degeneration. All right, so the lung cancer in this case is producing these Purkinje cell antibodies. Okay? Trying to motivate you to study first-year material with a couple of these questions. But we will actually talk more about that condition later in the course. Okay, one more, or two more. All right, good. So you're given an upper motor neuron finding, and so you would want to associate that with other upper motor neuron findings. So we've got a Babinski, right? So this patient most likely then would have hyperreflexia as something else you'd expect, another upper motor neuron finding. Fasciculations are a lower motor neuron finding. Now, we will talk, there is one distinct condition, ALS, or Lou Gehrig's disease, where you get a mixture of upper and lower motor neuron findings, but you don't have anything in the history that would suggest that. So we'll say more about ALS, but hyperreflexia is the best answer here. Yeah, fasciculations are lower motor neuron. Okay, so this is not a UWorld question, but in some ways this will always come out in a vignette of myasthenia gravis. Okay, good. So myasthenia, remember, it is antibodies against nicotinic receptors. Nicotinic receptors are on muscle. Okay, so you really only have weakness in myasthenia gravis. And so weakness, yes, of eyelid elevators. Okay, that's a muscle. Weakness of double vision, because of course all the neuromuscular junctions involved in moving your eyes. Dysarthria is very common in myasthenia gravis, leg weakness. These are all involved nicotinic receptors on muscle to do all of those things. The pupil, okay, pupillary constriction is acetylcholine, but it's muscarinic receptors. Okay, so the pupil would never be affected in myasthenia gravis. Pupil is always going to be normal. Okay, so that'll be for tomorrow. Any questions on any of the vignettes that we just did there? Okay, let's go back here and we will now talk about another muscle disease, inflammatory myopathy. Okay, again, kind of like the muscular dystrophies, there are a lot of things that we're not talking about, but these are clearly the ones that you need to know for step one, first year material. The primary inflammatory myopathies, dermatomyositis, polymyositis, and inclusion body myositis, or IBM. Okay, there are inflammatory myopathies associated with other diseases. We won't talk about those. And there are, most of those are rheumatologic conditions like lupus and so on. But these are the three that I think are important for you to know. So you can see these are not super common. Okay, nothing that we've talked about so far in this course is extremely common. That will definitely change when we get to peripheral neuropathy on Thursday. That's one of the most common conditions. You can see I meant to mention just a little bit more common in women. Okay, so again, proximal weakness is the key thing that should jump out at you clinically when you're talking with these patients. So just to say a bit more about that, you use your proximal leg muscles when you walk upstairs. And so these patients will often say that's a complaint. Going upstairs is really difficult, kind of need to pull themselves up a little bit. Anything, lifting up to do something is more difficult because those are proximal muscles. Right, so dermatomyositis, the pathophysiology here is quite different between dermatomyositis and polymyositis. So these are both autoimmune conditions, okay, but it appears that in dermatomyositis that the primary attack is actually against the capillary network, the microvasculature of the muscle, and then the muscles are secondarily affected, okay? And so the mechanism here is complex, and I think I actually changed the PowerPoint slide here, the wording of it at the last minute into your handout, which is, I think, a little bit more clear. But I would think of this as a complement-mediated vasculopathy. So it's an autoimmune process against the capillary network, and then the muscle fibers, as we'll see out around the periphery, are affected. Okay, so we'll come back to that. So dermatomyositis, the dermato, of course, would suggest the skin is involved. And that's a big clue to this condition. So these are usually erythematous scaly lesions that are over distinct areas. The malar or the cheek region is classic. Involvement around the eyelids is common, sometimes called a violaceous rash because it has a violet color. Okay, and it's the sun-exposed areas or heliotropic areas that are affected in dermatomyositis. Okay, so you can see the involvement of the cheeks here, the eyelids. Okay, and so, in a patient who comes in weak, and it's in proximal muscles, and you've also got, these erythematous lesions in the cheek and around the eyelids, then the diagnosis is pretty straightforward. They also tend to get these lesions along the extensor surfaces, okay, so along the dorsum of the fingers and along the knuckles. That's quite typical, okay, and so this doesn't show up that great, but again here on the extensor surfaces, they're more likely. So we've got some of these erythematous lesions here. And the reaction around the eye can sometimes be quite intense. So they've got the rash there, but then also there's some swelling with it, and this is called periorbital edema. So the eyes just look kind of puffy in these patients. Okay, lots of things are affected outside of muscle in dermatomyositis. There can be these subcutaneous deposits of calcium. Okay, that's called cutaneous calcinosis. And if we do an X-ray, you can see these calcified deposits here. Okay, so you've got the skin manifestation, the muscle manifestation, again, is proximal weakness. I told you yesterday that subacute means generally over weeks. Okay, again, a muscle disease does not affect sensory pathways, upper or lower motor neuron pathways, so reflexes are normal, sensation is normal. Okay, but the esophagus is skeletal muscle, and so that's affected in about a third of patients. So they may complain of choking on food, or swallowing a glass of water is difficult for them, swallowing pills can be difficult, but thankfully the respiratory muscles are almost never involved. So this tends not to be a life-threatening kind of condition. Now, myalgia just refers to muscle aches, which are seen in less than a quarter of patients, but I'll just mention it. Every national board type question I've seen, there are always muscle aches. Okay, so recognize that you don't have to have muscle aches. Most patients don't, but they're usually part of a national board vignette. Interestingly, kids get dermatomyositis as well, and so the muscle pain is more common in children. Okay, because of weakness, and often some muscles affected more than others, so we get some imbalance. We can have some joint contractures. Those can be painful. Okay, and there is a risk overall of a variety of cancers in these patients that are higher than the baseline population, so especially ovarian cancer. And there's some debate in the medical community once you've diagnosed dermatomyositis, how much screening do you do? Some people do a lot, some feel that it's not indicated, but you should be aware there is an increased risk of cancer, and I think some degree of basic screening is reasonable once you've made a diagnosis. Okay, there can rarely be a type of lung disease that's associated with dermatomyositis. Okay, so again, the diagnosis is usually quite suggestive. You've got a patient with proximal muscle weakness, you've got the dermatologic manifestation, but there are some things that can kind of mimic dermatomyositis, so you really have to nail down and make the specific diagnosis. So remember our blood test here, always if we're thinking of a muscle disease, you want to do a CK. Okay, and in this condition, because subacute weakness means this is progressing fairly rapidly, there's active muscle breakdown, so therefore your CK is always going to be significantly elevated, like in a Duchenne's or a Becker's muscular dystrophy. Again, very nonspecific, but it's just helpful. Yeah, you're correct in thinking this is a muscle disease. We've got a really high CK. Okay, EMG, I think we'll talk about Thursday. So this won't mean much now, but myopathic just means it looks like a muscle disease. And let me tell you on Thursday what that means. Okay, here's the very specific finding that confirms the diagnosis. You need a muscle biopsy. Okay, so usually you want to biopsy a muscle that's weak, where there's evidence of disease. So like the quadriceps would be a good muscle. Okay, it's a proximal muscle, it's large, easy to biopsy. And so you would look for this finding of perifascicular atrophy, which I'll show you a picture here. And again, this reflects kind of the pathophysiology of the condition. It's a complement-mediated vasculopathy. And so you tend to lose that capillary network around the periphery of the muscle fascicle. So those tend to be the muscle fibers that are affected. Okay, sometimes we will check these additional antibodies here. They're called anti-Jo1 antibodies. And if they're positive, that makes us more concerned about that rare lung disease that can be associated with dermatomyositis. Okay, so that's really all we would do in terms of workup. Okay, so Dr. Deich here will go over the pathology in a lot more detail, but this is one even I can look at and understand. Look at the nice healthy muscle fibers here in the center and out around the periphery. Notice how they're much smaller. Okay, so it's the peripheral capillary network that's affected predominantly, and so this is called perifascicular atrophy. So when you order a muscle biopsy, this is what you're looking for. This is the wording, and that's just highly specific. So you confirm the diagnosis. All right, so treatment I think is beyond really what you need to know in this class. So I won't say much except that steroids work great for these patients. So you put them on steroids and almost always there's a dramatic turnaround. They're getting stronger, things are improving. But I'll mention here in just a few minutes, steroids have some pretty bad side effects, a lengthy list of common side effects. So even though these patients respond well to steroids, we usually also use immunosuppressant medications in conjunction with steroids. Okay, the advantage there is the immunosuppressants, they have a steroid-sparing effect, meaning you can get by using less steroids to treat the condition if they're also on immunosuppressants. Okay, so we'll talk about this IVIG later when we talk about Guillain-Barré syndrome, but IVIG is something else if you've just got a refractory case. It's an infusion of pooled immunoglobulins, and the mechanism is not clearly understood, but simplistically it kind of tricks the body's immune system. You're getting all of these pooled immunoglobulins infused, and it seems to kind of shut down the body's own production of antibodies and things that are responsible for the disease. Very expensive. It's like $15,000, $20,000 for a 5-day course of this, but it can really get someone turned around in kind of an urgent situation. Okay, so just in summary for dermatomyositis, you look for the typical dermatologic manifestation, proximal weakness. I mention here and children because we'll contrast this with polymyositis, which we just see in adults. Joint contractures are distinguishing from polymyositis, where they tend not to have those, and then perifascicular atrophy. So these are kind of the distinguishing things from what we'll talk about next. All right, so polymyositis, the pathophysiology is a lot different. Now it seems to be T cells that are directed against and attack the muscle fibers, not against the vascular capillary network. Okay, The weakness is virtually identical to dermatomyositis, subacute proximal muscle weakness. Okay, but they don't have the skin lesions. Okay, they also have dysphagia, just like dermatomyositis. They also did not have the respiratory muscle involvement. Okay, muscle pain, maybe a bit more common, but again, no more than 1/3 of patients will have some achy muscle pain. They can also have an interstitial lung disease. So you can see it's very similar, absent the skin lesions. The risk of cancer seems less in polymyositis compared to dermatomyositis. Okay, and your workup is pretty similar also. These patients are also going to have a very high creatine kinase. You do an EMG, and the EMGer will report, yep, looks like a muscle disease, but they can't tell you what kind, just it puts you in a muscle category. But now when we do a muscle biopsy, there is no specific finding. That's the key thing. The muscle biopsy will come back and say, yep, you've got an active inflammatory muscle disease, but there is a long list of active inflammatory muscle diseases. So the report will not come back, this is polymyositis. So you have to use your clinical judgment at this point and say, yep, the history fits, the exam fits, the diagnostic testing has ruled out other things. That's what's really helpful with the muscle biopsy is there are some metabolic myopathies that can look a lot like polymyositis. You rule those out by doing the muscle biopsy. Okay, so it's not as specific as dermatomyositis where you get that perifascicular atrophy and okay, I just nailed it down. All right, so making the diagnosis, we've got a patient with subacute proximal weakness. The EMG and the CK fit for a muscle disease, and the muscle biopsy excludes other conditions. And then we begin treating the patient for presumed polymyositis. Okay, treatment is very similar as with dermatomyositis. So again, we start patients initially on high-dose steroids, and because of the long list of side effects, we try to get them down as fast as we can. Okay, because the longer they stay on the higher dose, the more likely they're going to have side effects. So patients usually come back, within 3 months, much, much better. Okay, now, probably this would not be a neuro question on step 1 boards, but I just thought it's so high yield, we're going to put it in here in neuro. I'm sure you'll get it again later. You definitely need to know the side effects of steroid medications. We use a lot of steroids in neurology for different things, and this is the reason that we work so hard. In fact, if we can get a patient down to an every other day dose of steroids, that's usually our goal, then these long list of side effects are much less common. So we start out with a high daily dose, and then we taper the patient down, and if we can get them to every other day, then they tend to do well. So we can have a steroid-induced diabetes. So the sugars go up, and sometimes we even have to treat a patient like we would, someone with type 1 or type 2 diabetes. It's especially troublesome if you diagnose a patient with diabetes with dermato or polymyositis, because now you want to put them on steroids, which is just going to make their diabetes that much more difficult to treat. Okay, so that's a common side effect. Chronic use of steroids tends to weaken the bones, so you get an osteoporosis. So again, if we just think about patient populations, if we diagnose a 70-year-old woman who maybe already has some osteoporosis, we worry about using steroids to treat that patient. Chronic use of steroids tends to shut down the function of the adrenal gland, and so extremely important here is that as you're tapering down on steroids that you not do it too quickly, and especially important that you tell the patient, do not abruptly stop your steroids, because it takes the adrenal gland a while to kick in once you've stopped steroids. So this can be life-threatening. I'm sure you will definitely learn about Addison's disease and the effects of this. So we always have to come off slowly and give the adrenal gland a chance to begin to kick in on its own. Cataracts are very common with chronic steroid use. So again, as a physician, you're helping the patient with the steroids, but if they get a cataract in a couple of years, you're going to feel bad about that. So that's treatable, but again, it's something that's iatrogenic. Iatrogenic means, we're doing it to the patient as a side effect of the medication we're using. Weight gain is so common with steroid use. There tends to be a swelling, round appearance to the face, sometimes called the moon face. Gynecomastia in men is very common, and you tend to get these fat deposits on the back. Skin becomes thin and fragile with chronic steroid use. So patients will tell you, they bump their arm and they get a big bruise. And so that's just the effect of chronic steroids. Mood fluctuations, this is usually when we're starting the patient on a high dose. And I've had quite a few patients that the spouse has called back and says, he is just manic. He hasn't slept in 2 days and he wants to buy a car. And, so this can range from euphoria and mania, or sometimes just, from that to severe depression. Okay, so you need to talk with patients about that before you start steroids. This kind of goes along with the insomnia of high-dose steroids. Okay, we can cause peptic ulcers, so we will often give a medication to prevent that when we start steroids. We worry putting steroids in a patient, for example, that needs surgery in a month because it tends to impair wound healing. Patients are a bit more susceptible to infection. Okay, and in females, it can cause amenorrhea and hirsutism. Okay, so I think every single one of these, I would really spend some time with this list. I think it's a very frequent type of a board question you would get, all the side effects of steroids, because they're commonly prescribed. And I think if I were making a top 5 list of medications that have the most side effects, steroids would certainly make the list. So here's a little picture that I found that I thought was a little helpful, pointing out most of the things that we've talked about. Okay, so just some other things. When we use prednisone, I think more and more neurologists now are doing a chest x-ray. You want to make sure a patient doesn't have tuberculosis, that the steroids may bring out some underlying infection. We'll do something called a DEXA bone scan periodically if they need to remain on steroids, so that we can monitor for the osteoporosis. And if that's getting worse, then we're going to be maybe more aggressive with other therapies. Again, we will try to do everything we can to prevent osteoporosis, so calcium supplementation and something called Fosamax if they have bone loss. Okay, I won't ask you this, okay, but I do want you to be aware of the osteoporosis and that's something we need to monitor. Okay, and we give a class of medications called proton pump inhibitors if they have any indication of that they're getting peptic ulcers. Okay, so it's complicated when you use prednisone. Now, the immunosuppressant medications, azathioprine is the one we use most often. Again, don't worry about specific numbers like this, but it's a good 2/3 of patients that have a good improvement on this. And so you're using this because it helps, but also because it has a steroid-sparing effect. You need to use less steroids in patients that are on immunosuppressants. But immunosuppressants, they're working for the condition by suppressing the bone marrow. Okay, so we need to monitor blood counts in patients on immunosuppressants to make sure we're not suppressing too much. These take a long time, up to a year, to do anything. Okay, so you start a patient on this and you tell them this is for the long term. You're not going to get a benefit from this immediately. Okay, and like I mentioned with dermatomyositis, IVIG is another treatment that we'll consider. So a patient that has diabetes and osteoporosis, and we really do not want to give steroids, then we can give IVIG every 3 months. Okay, extremely expensive, but you don't get that long list of side effects. So we do actually use a fair amount of IVIG for both poly and dermatomyositis. Okay, now the last one, when I was in medical school, this condition was not even known. In fact, inclusion body myositis was called polymyositis. It was felt there was a category polymyositis that just didn't respond to the treatment. And now we know this is a distinct entity. But inclusion body myositis is quite common, so you need to know about this. The pathophysiology is quite similar to polymyositis, so it's T cells attacking muscle fibers. But clearly there are some differences. Okay, one, as we'll discuss, there's no treatment for this, so unlike polymyositis. Another is there's a hereditary genetic factor, which we really haven't identified with polymyositis. Okay, so when you think of polymyositis, think of an older man coming in with weakness. That is the patient population. So I wrote older than 50 here, but tends to be older than 65, 70 most often. So we would think about this, really, when you have an older man coming in weak, I don't remember where it ranks on a top 10 list, but inclusion body myositis should come to mind. So here's what really is quite specific for inclusion body myositis. There are two muscle groups that are uniquely affected. And again, it's not known why, it's just the way it is. But it's quadriceps and finger flexors. Okay, now, quadriceps, will cause your legs to buckle, right? So what they will say is they're walking along and then their legs just give out and they fall. Okay, finger flexor weakness, that's unusual. Most neurologic conditions like stroke tend to affect the extensors. Okay, but the finger flexors, what that would mean is, a patient may complain they can't open jars because they just can't squeeze down tightly on the lid. So you need to remember to check that on examination. It's really remarkable. You have the patient hold their fingers out, they're pretty strong with extension, and then you have them turn the hand over, and I have a patient who's great doing this, and then when I have him turn the hand over, he can just barely do about that much. Okay, so that's quite a specific exam finding. I don't know of any other condition that does that. So we've got an older man with that kind of pattern of weakness. He has inclusion body myositis. So these patients tend not to have myalgias. Again, all three of these have dysphagia. It's maybe a bit more common in IBM. And these patients can actually have a little sensory peripheral neuropathy when you do an EMG. But that's usually not a big deal clinically. They don't tend to complain of that. Okay, so you're suggestive of the diagnosis based on the clinical picture. You do a CK, and inclusion body myositis tends to be less rapid than poly or dermatomyositis. So it's maybe over many months or even years that the patient is having the complaint. So therefore, the CK is usually not dramatically elevated. Okay, you can do an EMG, and again, it looks myopathic. I'll talk about Thursday. But in this case, like dermatomyositis, we have a specific muscle biopsy finding. So we find rim vacuoles, okay, and you see these inclusion bodies. That's why it's called inclusion body myositis. And so these are quite specific. You want to do electron microscopy, and you can prove that these are 15 to 21 nanometer cytoplasmic and intranuclear tubulofilamentous inclusions. Okay, I'm sorry, I didn't come up with all the wording there, but that's what you want to identify when you do electron microscopy. Now, thankfully, there is a blood test that came out in 2012, and it's just in the last couple of years that we're able to do this commercially. Antibodies have been found against cytosolic 5-nucleotidase 1A, and these are antigens that are in skeletal muscle. It's thought they have something to do with DNA repair metabolism, not entirely clear, but these are found in patients that have inclusion body myositis. And I put the sensitivity and specificity there in your handout. They're pretty good. They can be positive in other conditions, so they need to be interpreted in looking at the patient saying, yeah, I think the patient has IBM, and then if the blood test is positive, then that would support your diagnosis. So we're doing this more and more now to confirm. But if you do a biopsy, here we see these inclusion bodies in the muscle fiber. And if we do electron microscopy, these are these tubulofilamentous inclusions here that Dr. Deich is going to tell you more about that as a neuropathologist. Okay, so this is what you're looking at here, these inclusions in the muscle fibers. I had a great patient maybe 6 months ago with inclusion body myositis, and I asked if I could video him for this course because he would just be a great one to show you the finger flexor weakness, and deleted the video from my phone by accident. So sorry I can't show you, and I haven't seen him back, unfortunately. All right, so treatment, unfortunately, everything has been tried, like for polydermatomyositis, all of the steroids and IVIG. Nothing helps for this condition, unfortunately. All right, so we'll stop there and see you tomorrow morning.